Okay, so picture this. Your patient just finished a big dinner and now they're clutching their chest, face pale, telling you they have this awful, crushing pain. Is this a full-blown heart attack, or is it just really, really bad heartburn? This is one of the most high-stakes questions you will ever face as a nurse. And listen, getting this wrong is a fatal error. It's no joke. It has massive consequences for your patient, obviously, but also for you on your board exams. The NCLEX absolutely loves to trip students up on this exact scenario. So today, we're going to make sure you get it right every single time. So let's get right into it. The GERD chest pain trap. Before you even think about the GI system, there is one absolute non-negotiable rule. I want you to burn this into your brain. I mean, tattoo it on your forehead if you have to. When a patient comes in with chest pain, it is always cardiac until proven otherwise. I don't care if they just ate a 5-alarm chili. We are getting that EKG or drawing troponins. We are ruling out the heart first. Only then, and I mean only then, can we even start thinking about GI stuff. This will save your patient's life, and it will for sure save you on the NCLEX. Okay, so we've done our due diligence. The heart is fine. Whew! Now what in the world is going on in their gut that could mimic a heart attack? Let's break down the 3 usual suspects. First up, we've got good old GERD. And really, it all comes down to a faulty valve. You see that little muscle at the bottom of the esophagus, the LES? It's supposed to be a one-way street. But with GERD, it gets kind of lazy, it doesn't shut tight, and that lets all that nasty stomach acid splash right back up where it doesn't belong. And let me tell you, that burn can feel exactly like crushing chest pain. Now, sometimes the problem is, well, plumbing, a hiatal hernia. Look here, on the left, everything's where it should be. But in the middle, you see that sliding hernia? The top part of the stomach just slides right up into the chest. And on the right, you've got the paraesophageal kind, which is way more dangerous, where the stomach squeezes up next to the esophagus. Either way, you've got part of the stomach in the chest, and that totally messes with that valve we just talked about, leading to, you guessed it, reflux. And then there's our third troublemaker, gastroparesis. Now this one's different. It's not a reflux issue, it's a motility issue. See how the food is just sitting there? This often happens with nerve damage, like from diabetes, where the stomach muscles basically get paralyzed. The food has nowhere to go. It's like a traffic jam in the stomach, causing major bloating, pain, and fullness. So think of it this way. It's not a plumbing problem, it's more of an electrical one. The signals just aren't firing right. Okay, we get the what, but now for the really important part, the so what. As a nurse, what are the absolute dangers you need to be watching for? What are the screaming red flags? And this is a big one, guys. Huge. Look at the image on the left. That's a normal, healthy esophagus. Now look at the right. That is Barrett's esophagus. After years and years of getting torched by stomach acid, the cells literally change. They become precancerous. So please, please hear me on this. That chronic, oh, it's just my heartburn, is not just annoying. It's a major risk factor for esophageal cancer. Okay, safety alert. Remember that paraesophageal hernia? The one that squeezes up next to the esophagus? This is why we worry about it so much. That little pouch of stomach can get twisted and cut off from its blood supply. We call that strangulated, and it's a massive surgical emergency. So if your patient with a hernia suddenly gets super full, can't catch their breath, and has severe chest pain, you need to sound the alarm, and fast. All right, so to figure all this out, the doc's probably going to order an EGD, and your job here is critical. Beforehand, yeah, it's the usual. NPO, make sure consent is signed. But after the procedure is where you really shine. The number one thing, and the NCLEX loves this, is you have to check their gag reflex before they get a single drop of water. Their throat is numb. No gag reflex means nothing by mouth. Period. Then you're on high alert for bleeding, and especially perforation. That's a hole poked where it shouldn't be. The telltale signs? Severe pain and a fever. That's a call to the doctor, stat. So how do we get all this to stick in our brains for the exam? And more importantly, how do we teach our patients to manage it? Don't worry, I've got some tricks up my sleeve. For patient teaching, it doesn't get easier than this. Just remember the word GERD. G is for get the head of the bed up. Gravity is your friend. E is for eat small, low-fat meals. R is for reduce those triggers. We're talking caffeine, alcohol, all the spicy stuff. And D is for don't lie down right after you eat. Wait at least 2 to 3 hours. See? Simple. GERD. And let's add a few more pro tips to that list. Tell them to avoid tight clothing. You know, anything that squishes the belly just pushes that acid up. Losing weight can make a world of difference. Oh, and good oral hygiene is a must, because that acid can wreak havoc on their tooth enamel. And for your gastroparesis patients, the advice is a little different. Chew your food really, really well and steer clear of high-fat and high-fiber meals that are just harder for that sluggish stomach to break down.
Real quick on the meds, you're going to see two main types. You've got your H2 blockers, like famotidine, which kind of turn down the volume on acid production. But then you have the big guns, the PPIs, or proton pump inhibitors, like omeprazole. They don't just turn it down, they shut the whole factory down. They stop that final step of acid production. So, two different ways to tackle the same problem.
All right, enough talk. You've got the knowledge, so let's see you use it. Time for a classic NCLEX style question. You ready? Okay, here's the scene. Your client just got back from an EGD. They're complaining of a sore throat, but they also have a temperature of 101.5 Fahrenheit. So, what's your priority action? What are you going to do first? Take a second, think it through. The answer, without a doubt, is number 3. Notify the HCP immediately. And here's why this is so critical. A sore throat, totally expected after a scope, but a fever, that is a huge, flashing red light for perforation. It's a life-threatening emergency. Giving ice chips or pain meds would be a dangerous delay. You have to escalate this right now.
Okay, let's lock this in with a rapid recap. You ready? Rule number 1, the golden rule. Chest pain is cardiac until proven otherwise. No exceptions.
Recap number 2, post-EGD. Your absolute first priority before they get anything to eat or drink is that gag reflex. No gag, no go. Protect that airway.
And recap number 3, never ever blow off chronic heartburn. It is not just heartburn, it's a serious cancer risk. What you teach your patients can literally save their life.
So there you have it. You've totally got the priorities down now. So my question for you is this. As you go into your next clinical, what's one simple change, just one little thing, that you can teach a patient this week that could make a huge difference for them? Think about it. That's where you go from being a student to being a real nurse.